Let me know if you can see the screen.
Yeah, we can see it now. You can go ahead.
Okay. Well, firstly, I'd like to thank Dr. Asad Chaudhry for this, arranging this, and the support from Usman and Frozen's generally. I just want to say about Asad that we haven't had many interactions, but he really is a gem of a person, and the work that he is doing for the field in Pakistan is extremely commendable. So I just wanted to start with that. And with that, I'll get going here. So endoscopy and COVID-19, just some like background information. We're all in this together. We're all learning from each other. This is not meant to be, this is how this should be done. The reality on the ground in every country is different, and the rules have to vary based on where you are. Having said that, I think one thing that is common for all of us is that prevention is better than cure, especially when there isn't a cure, and we're hopeful and we're optimistic about various things coming up. But the reality is that right now, there's nothing that's substantially beneficial. In terms of endoscopy and the COVID-2 or COVID-19 virus, multiple societies have published their guidelines. This is just a selection of a few. The combined guidelines from the 4 US gastroenterologic/hepatology societies came out on April 1st. And then prior to that, the European Endoscopy Society published its guidelines, and the British Society of Gastroenterology did too. So I won't necessarily go into all of them in detail because I think the principles are the same. But there are two key components to the management of patients with COVID-19. One is to reduce the spread, and the second is to enhance safety. And I think these are the vital ones that we need to keep in mind when we're considering endoscopy in our patients. So it goes to say, to do that, you have to minimize endoscopy. There isn't a question how and why. The question is, we have to do it because that is how we reduce the spread. The way we go about it is that we only perform truly emergent and urgent endoscopies, again, to reduce the spread. That determination is made on a case-by-case basis, and there are some broad guidelines, and we can go over that. And the other component is safety, appropriate usage of personal protective equipment, PPE, which varies depending on the availability. When we have patients who have confirmed disease, then the safety issue is even higher. We just have to use extreme caution, take the best precautions possible, and then hope that we don't pass the infection along as well as contract it ourselves. So just some basic principles. I think most people understand these, but I will say that even amongst some very, very educated people, sometimes these concepts get lost. So I'm just going to briefly go over these. The R naught, or the reproductive number, is how contagious a disease is. If it's less than 1, the disease is not going to spread because one case will lead to less than 1 infection. So by and large, the infection will die out by itself. If it's equal to 1, one case will lead to 1 infection. Diseases will stay alive and stable. And if it's greater than 1, this is where the problem occurs. Each case of infection will lead to more than 1 subsequent person becoming infected. And then that person will have infect more people, so you have a multiplicative effect. If we look to the side here, some of the other SARS infections were extremely infectious compared to COVID-19, but the difference was that they were more obvious in their presentation. MERS and SARS were way up there. Having said that, they were more toxic in terms of their case fatality, but their infectivity rate may not have been high for MERS, but SARS was slightly higher. And if you look at measles on the right, it's not as morbid, or the mortality isn't high, but it is highly contagious. So with that in mind, this is the principle. We decrease the spread, reduce the number of infected people, reduce morbidity and mortality, and preserve healthcare resources. And that's where flattening the curve comes in. And this is extremely important when healthcare resources are restrained. And what we found out is that it doesn't matter where you are on the planet, whether you're in the United States or in quotes, lower socioeconomic / developing country, resources are going to be limited. So the idea is by reducing spread, we flatten this curve, and therefore we reduce the disease burden both from a resources standpoint and human perspective. So where are we right now? In the US, unfortunately, the curve seems to be still going upwards. In Italy, it seems like it's finally steadying itself and the mortality may be coming down. This is all data yesterday afternoon from the Johns Hopkins site. This is what I got from the Pakistani government this morning. Now, this has caveats like every other country based on the amount of testing being performed as well as the number of mild disease cases. In terms of where Pakistan overall sits with the rest of the world, fortunately, it looks like the disease may not be as severely presenting itself. We're hopeful that's the case. It's possible that we're underdiagnosing the disease too. So we have multiple variables here. In terms of the US, I think Dr. already mentioned this earlier, the spread is very variable. And I think it's something to do with also partly multiple factors, but how soon people started making conscious efforts to stop the spread. And in the US, the term that's used often is the shelter in place, restricted movement. San Francisco, where fortunately Bilal and I are currently, was one of the first cities to enact that order. And we feel that that seems to have helped in California, in San Francisco especially, though of course there are multiple factors. This is the map for the US as of yesterday afternoon. And you can see New York is the trouble spot, followed by New Jersey, Michigan, and California on the West Coast is doing okay, relatively speaking. So the other important component in this is resources are not just in terms of masks and gloves and various physical supplies, but the human toll in resources. And this is not to be underestimated. Physicians and healthcare providers dying is a big issue for multiple reasons. A, just for their personal families and lives after years of dedication to the field to die from the disease. But second, and this goes for nurses, of course, we had the initial physician who first sort of rang the alarm bells in China, who I feel like falls in the category of a martyr in this whole scheme of things. But importantly, when you have limited resources in a country like Pakistan, with specialists of every field, relatively few compared to the general population, it is really important to save those resources. So the idea is not that we want to be protective of our lives, but the idea is on a national scale, we have to be responsible. There are no heroics. Endoscopy is not something that has to be done unless it's absolutely necessary. Avoiding unnecessary procedures will save lives, not just of the general population, but the healthcare system too. So with that, I'll just briefly go over the guidelines that the multiple societies in the US published, and basically they list things that should not be delayed. This is all relative based on what resources we have. But the key things are, if it's life-threatening, it really should be done. Also, if the patient's in the hospital and is prolonging their hospitalization, likely it should be done. The big three here are GI bleeding, dysphagia causing obstruction, cholangitis. Beyond that, all of these need to be done, but there is a timeline based on which we can decide when it needs to be done. If they're inpatient, obviously we do them. The AGA has its own paper coming out, and that's essentially putting it pictorially in a little sort of graph as a quick guide what to do. One thing to remember with cancer patients, at least some of the preliminary data suggests that their outcomes, as expected because of their immunosuppression, will be worse. So when we're thinking, oh my God, we have to do this procedure because this is a cancer diagnosis, these are also the patients who, when they get the COVID-19 infection, are at a high risk of mortality, especially when it comes to lung cancer. But cancer in general, as expected, will have worse outcomes. Everything else, you can just wait. Screening, which is a big part of the endoscopy culture in the US, has to wait. Anything that is non-urgent, including varicose banding, for instance, has to wait. EUSs for a lot of things wait. Motility obviously waits. We don't need to spend too much time on that. A couple of interesting sort of phenomena that we are observing, mostly data from China, that in patients who recover from the infection, this is a series of 22 patients, what they did was they also looked after the pharyngeal swabs became, they checked multiple sources, pharyngeal swabs, mucosal sampling, and stool sampling. And one of the findings was that if you look at this dark line, this is the RNA positivity rate. The dark dots suggest a positive stool sample for RNA. So even up to 47 days out, there is shedding of the virus in the stool. Now, it's not clear whether this necessarily implies infectivity, but it goes to show that the virus is in the human body long after the pharyngeal swabs will become negative. So that implies that there is possibility of ongoing infection silently without us, infection spread silently without us realizing. In terms of PPE, this is a big sort of area of controversy that over the last couple of weeks seems to have been settling itself, at least in the US. Generally speaking, again, physical distancing, adequate hygiene are the main sort of points. All elective procedures should be postponed until after the surge. All members of the endoscopy team should wear a full set of PPE predicated on resources available. That's kind of common sense. A lot of this is common sense. The correct sequence of putting and taking off PPE is critical. I'll show you a figure of that in a bit. And then in terms of N95 or equivalent respirators, this is obviously for patients with known COVID-2 infection, it's paramount that as long as we have it available, it must be worn, and there are all these protocols that are being established. The challenge becomes, what if you don't have these? And that's the very challenging situation. All healthcare providers should have N95s fitted by occupational health specialists if possible. Staffing of endoscopy rooms should be reduced. You know, there's a big issue with training of GI fellows, trainees, but the bottom line is safety first. At least at our institution, fellows have been excluded from procedures for now. Only the attending is performing the procedure. In case of shortages, may require to extend limited reuse of N95s. And actually that has essentially become the guideline for the most part. The US Surgical Society has issued a guidance for cycling N95s every 4 days in order to minimize the risk of running out of these masks. In terms of the room and the cleaning of the room for endoscopy, there is no need necessarily to have anything beyond the current standard cleaning endoscopic infection. In terms of room cleanliness, the guidelines are that obviously we need to give the room enough time for the virus to, in quotes, dissipate. At our institution, based on the size of the room and the ventilation, there are different guidelines. In the OR, there's a 15-minute delay in terms of entering the room after everybody has left, in terms of cleaning it and reprocessing it. In our endoscopy rooms, because they're smaller and they don't have the same kind of ventilation, it's actually a 35-minute rule. So just sort of moving on with some of our locally institutionally based guidelines, and this is in a resource-rich country at a resource-rich institution. We do not have the same shortages that we have even in New York, let alone other countries. But here are some pre-procedure instructions that we're providing to patients before they even come in. This is the day before or a few days before electronically they're getting via their chart. That visitors are restricted from entering the hospital. The patient is allowed to come into the hospital, but any relatives, any family members stay outside of the hospital. If you're not going home on the day of the procedure, we ask that your family members and visitors stay at home. If you are going home, the family member will not be able to accompany you into the pre-procedural area in an effort to practice social distancing. If they live locally, they're encouraged to go home. If they're coming from a further distance, they're advised to stay away and practice social distancing. And that at arrival for the procedure, patients are going to undergo a health screening with questions related to symptoms of COVID-19. Additionally, any children under the age of 18 are restricted from entering the hospital. So what happens once the patient enters the building? At the very entrance, there is a team of nurses who do a screening, and they will ask these standard questions: fever, cough, shortness of breath, muscle aches. If they don't have any of these, they will follow the standard flow and get the patient to the appropriate procedural area. Interestingly, we are not measuring temperatures, which one could argue that we should be doing. If, however, they have any of these above mentioned symptoms, then an appropriate pathways sort of started in terms of getting them either to the emergency room or to a respiratory screening clinic for further evaluation. Once they're there, we pretty much are on our side following the same protocols of wearing a mask, even as we interview the patients and then performing the procedures. Now, at UCSF, the policy in terms of masks has changed. Endoscopy in the last week. Endoscopy was categorized as a high risk for aerosol generation procedure. And as a result, for every endoscopic procedure at this point, an N95 mask has been recommended for the entire team, whether that's if it's conscious sedation versus anesthesia, sedation, lead sedation. And of course, we have the usual PPE guidelines. So that means that we're wearing an N95, and what we're typically doing is wearing a surgical mask over the mask, N95, for that particular case. And at the end of the case, we're disposing of the surgical mask and leaving the N95 on, potentially throughout the course of the day. And subsequently, we're then storing it to be reused in 3 to 4 days. In terms of hand hygiene, as well as putting on and removing PPE, there are guidelines issued by the CDC, which everybody has been instructed to sort of be familiar with and follow. But essentially, there's stepwise progression: gown, mask, and then face shield, gloves. And the reverse is that once at every step you wash your hands. You take off your gown and your gloves, you wash your hands, you leave the procedure room, you take off your face mask, wash your hands, and then so your eye protection, you wash your hands, and then you take off your face mask and wash your hands again. Again, these are resources available to us. And in terms of decreasing the utilization of PPE, there are guidelines for what can and cannot be reused. So essentially, anything that has enteric contamination has to be disposed of. Gowns and gloves have to be disposed generally, and face masks, pre-procedure face masks, obviously the N95 stays is reused, as well as if there's a PAPR. Goggles and face shields are being cleaned and reused as well. In terms of our volume, so this is our data. So March 16, we initially made the efforts to cut down significantly. The following week was where we really cut down, and the previous week that just went by, it seems like the volume was slightly higher, and this is somewhat to be expected. Our average case volume per week is about, averaging about 300 cases a day. And in the first week, the instructions actually, the action occurred over the weekend, and we over the weekend started calling patients and canceled a lot of cases, but some had to be done. We were at 58. The second week, we were down to 16, and week 3, we were down to 33. We are in the process of collecting data on how many of these patients actually have subsequently tested positive for COVID-19. Some facts related to what I primarily do: the US volume, you can see a total of 10 cases in 3 weeks. We markedly reduced our volume. And ERCP 14 2 and 7, and these are primarily driven by cancer and transplant patients that had to be done. About a 50-50 split inpatient versus outpatient. So in conclusion, I would say primary goal is to reduce spread, save lives and resources. Endoscopy only if it's absolutely necessary. Hand washing and PPR are critical at the time of endoscopy, and they have to be done based on the resources available. Our challenges ahead will be figuring out how best to resume endoscopy. This is looking ahead. Hopefully the end is going to be sooner rather than later. But resumption of endoscopy, how do we actually implement that? Risk of spread as we reduce a second wave. I think some of the key things will be antibody testing for providers and patients to know if they've been exposed already, rapid testing for active disease, treatments and vaccine. Of course, some of these will take time. Finally, as we all talk about these, this too shall pass. We all have to stay positive, and as a community, we need to continue to rise to the challenge and learn from each other. And with that, I will end and take any, and pass back to the moderators. Thank you.
All right, Mustafa, that was outstanding. Thanks so much, Bilal. Thank you as well. So